This is Dr. Mark A. Bell, continuing with the third part of our series on screening in primary care. The next piece will be talking about unique challenges in screening. These are things that are somewhat unique to screening, not entirely, but to some extent. Things like lead time bias, length time bias, the issue of survival versus mortality that we've already touched on, healthy volunteer bias, cost and cost effectiveness, the issue of overdiagnosis, which will be dealt with in a separate section, and then just the general complexity of modern screening programs. So lead time bias is one of the most important to understand, and this diagram shows three patients. In the first, the patient is born at the left side of the slide. They live a certain amount of time. Symptoms appear of cancer, they're diagnosed with cancer, and then the red bar indicates the survival time from diagnosis of cancer till death due to that cancer. Situation 2, there's a screening program in place so the cancer is found earlier, but they still die at the same time. That yellow bar is the lead time. Cancer is detected earlier. It gives the illusion of longer survival, and it is longer survival from diagnosis, but it's not longer in terms of the years lived or mortality. As we discussed earlier, the important outcome to focus on is mortality, not survival, because of this lead time bias. Our goal in a successful screening program is that we detect the disease earlier, that's the lead time is still there, but that this earlier treatment results in longer overall survival, so life is extended and death may occur either due to the disease in question or to something completely different at a later period, so mortality is reduced. It's an example of lead time bias with regards to lung cancer screening. Mayo Clinic study randomized patients to chest x-ray or to usual care every 1 to 2 years. And the 5-year survival for lung cancer was 35% in the screening group and only 19% in the control group. But that's survival from diagnosis, and it's biased by lead time. When they looked at mortality rates due to lung cancer, they found that they didn't differ. In fact, it was just a little bit higher in the screening group than in the control group. So there's no true benefit in terms of reduced mortality. The most recent data from the PLCO trial, where they randomized over 150,000 men and women to chest x-ray annually or none for 4 years, found no difference in mortality after a full 13 years of follow-up. So again, the outcome of interest should be mortality, either disease-specific or all-cause, and not 5-year survival. So length time bias is a bit different. They sound similar, length time, lead time, but they're quite different. Length time bias occurs when you have a screening program in place, and that screening program is more likely to detect slower growing or indolent cancers. Think of it as there being more time to be able to detect these. If a cancer is very rapidly growing, it may appear and go from a screening detectable state to a symptomatic state between screening intervals. And so screening may be biased. So if you look at the diagram at the right, you have some very fast-growing tumors at the top, rapidly progressive. Only 2 of those happen to get caught by the screening test. The bottom shows a more slowly progressive, a longer arrow, a longer period of time from onset of the cancer to its causing clinical symptoms. 4 out of 6 of those cancers are diagnosed by screening. So what that means is in an observational study, a screening program will detect more indolent cancers that tend to have a better prognosis, but that's simply an artifact of how long those cancers are around to be detected. If you do a randomized trial, that eliminates this length time bias and provides a more objective estimate of benefit. So to summarize, lead time bias means that earlier detection results in longer survival from the time of diagnosis, but it may or may not result in reduced mortality or longer overall life lived or overall survival. Length time bias means that a longer preclinical phase of a slower growing cancer makes it more likely that screening detects these, quote, favorable cancers with better outcomes, and in an observational study that can make screening look like it's more effective. Both of these problems are present when you use observational studies to examine screening programs. That's why we have to be very, very cautious about interpreting observational data from cohort studies or case control studies in screening programs. On the other hand, randomized trials eliminate these biases if they're done properly and really should be our primary source of information. The healthy participant bias is also called the healthy volunteer bias. And this data from the AGE trial in England on breast cancer screening in women in their 40s illustrates it really nicely. This was a large study where they invited 50,000 women to attend screening, and they compared them to 50,000 women who weren't invited. So they began to invite these women age 40. About 2/3 showed up. They also looked at the overall outcomes in the women who were invited but didn't come in. So comparing those who volunteered with those who didn't. What's interesting, the attenders, those who volunteered for screening, and that's the only difference between them and the non-attenders, they had a much lower rate of all-cause mortality. You can see in the blue box there, 1.25 versus 2.53 deaths per 1,000 women years. Presumably those women who volunteered for this trial looked and behaved differently than those, or had different health habits than those who didn't. Perhaps they were more attentive to other aspects of their health, wore their seatbelts, did all sorts of other things that are health positive behaviors, maybe ate a good diet, less likely to smoke, resulting in lower all-cause mortality. That can be misleading if you were to compare only the attenders in the one group with all comers in the comparison group. That could make it appear that screening is beneficial when it's really just this healthy volunteer bias. So this has important implications when we're designing trials. In the first design, you could randomize patients to two groups, invite patients from group A to screening, and compare only the attenders in group A with all of the patients in group B, both attenders and non-attenders. This would bias strongly in favor of screening, since those non-attenders in group A with worse outcomes have been excluded. Design 2 would invite patients to screening and then randomize the attenders to screening versus no screening. So you invite them first, then you randomize. That eliminates this potential bias. Screening recommendations are becoming increasingly complex. The National Lung Screening Trial found a net benefit with a number needed to screen to prevent one death over about 5 years of around 300 for lung cancer and 200 overall in this very large lung cancer screening trial using low-dose CT. During the study period, there were 79 fewer deaths due to lung cancer among the 26,000 or so participants, and it is a B recommendation. There were also fewer all-cause deaths. The infographic shows, though, that it can be fairly complicated to figure out whether or not someone should be screened. First, we have to think about their age, whether or not they're currently smoking, their PAC years, and would they be willing and able to have treatment for lung cancer if they screen positive. So it's getting fairly complicated, and this is showing the protocol for the National Lung Screening Trial. If there was a new nodule detected on the far left-hand side, first you look for suspected inflammation. You consider doing repeat low-dose CT, and then sometimes repeat it again or move on to PET scan. Ground glass nodules, solid nodules get treated differently. Essentially, it's a very complicated algorithm that's designed to minimize the need for additional biopsies or surgeries. If you don't follow this protocol, there's a potential for significant harm. Another issue is that the risk due to surgery was lower in the National Lung Screening Trial than in other studies, about 1% versus closer to 4%. So if screening is done in a setting where they have higher surgical mortality, that might wipe out the potential benefit of screening. They also used low-dose equipment, newer equipment. The protocol was strictly adhered to. Any of the things If we don't adhere to any of those things, there's a potential for increased biopsy rates and increased harm. So one of the real concerns is if we do find a benefit in a large randomized trial, can we duplicate this benefit in more of a community setting? Finally, this issue of cost effectiveness. The National Lung Screening Trial enrolled patients 55 to 74, and some of those patients were 80 by the end of the study. They had 30 pack years of smoking. They also included patients who had quit up to 15 years ago. They were, after this study was published and the recommendation came from the USPSTF, about a year later, this study was published in the New England Journal. And what it shows is that within that NLST group, there was a wide range of cost effectiveness. The final column shows the cost per quality adjusted life year. 1 year of life in perfect health is 1 QALY, death is 0 QALYs. And what you can see is that, the usual cutoff is between $50,000 and $100,000 per QALY. And what you see is that if you look at the age at entry, people 60 to 69, it was quite cost effective, less so over 70, and much less so under 60. Former smokers, it's very non-cost effective, but for current smokers, it was quite cost effective. And for people at the highest risk of lung cancer based on a standardized risk score, again, very cost effective, much less so if they're in a lower risk group. So if you're going to be making recommendations, let's say Ireland or whichever country you're in decides that it wants to adopt a cancer screening program, how would you decide? Why don't you write down your answer and then let's proceed to the next slide. So there are a bunch of reasonable strategies. If one option would be all persons 60 to 69. That's more egalitarian than limiting it to women, although you could make an argument that women, it's much more cost effective than men, so maybe we should just screen women 60 to 69. Maybe all current smokers 55 or 60 to 74, because current smokers seem to have the greatest benefit. Perhaps we should do a formal risk assessment to identify their quintile of risk and then limit it to those top quintiles of risk. But doing that kind of a risk assessment in a busy GP or primary care setting is challenging. So hopefully you have a better appreciation for some of the unique challenges of screening after going through this module. Lead time bias, length time bias, healthy volunteer bias, and the complexity of recommendations and identifying cost-effective options are all challenges that we face in screening.